especially related to underage patients, because our patient today is 16.
Oh.
Okay? So we're going to kind of get into that. That is not coverable material right now, but it might be when it comes to ethics and all of that. So again, some of the things we cover in this scenario are not testable to this first test, okay? But I'll kind of point those things out as we go along. So, you're working in a local clinic, okay? You are the nurse in the local clinic that provides care to women and children. And you have a client who brought in her 15-year-old, actually she's not even 16, she's 15-year-old daughter, Simum, y'all like that? Mm-hmm. For care today. She is here to see the doctor or the provider because she's having periods that are irregular. She's having emesis, back pain for the past week. And she's the oldest child with two other siblings who are age 10 and 6. She denies being sexually active. When you interview her with her mom in the room, what is the most appropriate thing to do now?
Ask to speak to her alone. Yeah.
Okay. We can ask mom to step out. But again, does mom have to step out?
No.
No. Because is she of legal age of consent?
No.
No. Absolutely not. And so there's a fine line here. Okay? So again, can we proceed without having mom step out? Do we have to know if she's sexually active or not? Now we can ask her if she'd like mom to step out. And if she would, we can then approach mom and say, look, since this is kind of a sensitive matter, do you mind letting us just have a few minutes with her to do the exam because it might be more comfortable for her?
I don't know.
Those are things we can do, but we have to be really careful, okay? So the doctor's asked you to obtain a urine specimen, and while you're directing the patient to the restroom in private, she admits that she's really sexually active, but does not want her mom to know. She says that she uses condoms that she got from school every time that she has intercourse, because it's legal for students underage to get condoms at school, right? Did y'all know that?
No.
Yes. Okay, so there's some things that a parent doesn't have to be involved in consent. And one of those is pregnancy, reproductive rights, right. So if they have a school program, and really, even when they don't, most of the time in a high school, the nurse has a bucket of condoms in her office. Did y'all know that? How many of you have kids? Did you know that? So, again, that's part of the law to decrease the amount, because guys, I'm sorry, your kids might be having sex. The truth is, I was working at a clinic, a school-based clinic, seeing elementary and middle school kids, and one of the things was that the school would not allow me to do that. That was the one. Could not talk sex. Could not. Do you know how many girls came to me asking for a pregnancy test?
Wow.
I couldn't bring it up, but guess what? I couldn't do it because the school forbid it. They happen to be in a school district that in order for us to have that clinic there, we had to agree we weren't going to go there. So guess how many kids were not being tested for STDs? Guys, these were middle school kids. And I think that we had one before I was there that apparently got hid the whole time. I'm not sure what the outcome was. I'm not sure what happened. She was a diabetic.
Oh, no.
And the nurse couldn't go there. Okay? I know. How shocking. So, again, we have to be realistic. It's all about education. So, I'm going to get off my soapbox. So, she says that she uses condoms and that she has intercourse, but her last normal menstrual period was March 10th. Today is June 17th, and although she has had some bleeding, she's not had any spotting since May. So she hasn't had any bleeding since in May. So based on the new information, the doctor orders what? A pregnancy test that is positive. Okay? So her pregnancy test is positive. Is a positive pregnancy test a presumptive or a, what category does it fall in when it comes to pregnancy? Probable. It's still probable, okay? It's either probable, presumptive, or what's the other term? Positive. I guess that should have been easy, it just didn't seem right. So, okay. So, again, you have to know whether or not. Now, why is that not a positive? She's positive for HCG, which is the hormone that is released during pregnancy. Why is that not a positive?
Some cancerous cells also produce HCG, so therefore it's not definitive.
Somebody's been doing some studying, okay? You can have HCG in your system and it not be a true pregnancy, okay? And most of the time it's called a hydatiform mole, which is an abnormal growth in the uterus that may have started as a fetus, but it's overgrown tissue that is cancerous. Okay? So what are things that would be probable? Okay, so that's a presumptive. What are what would be a probable pregnancy sign? Probable. Huh?
Spotting.
Okay, so not quite spotting.
You're talking about,
So that would be much later. You're not going to have Braxton Hicks now, huh?
you're talking about probable?
Probable.
It'd
What?
be more.
Abdominal enlargement. Nausea and vomiting could be, but nausea and vomiting could also be from a UTI or an illness.
What about a heartbeat?
Sorry, Dr. Bell, we looked at this place because I'm going to be confused. It has those under the hospital in the book. It has these.
Well, those could be, right, those could be, but I want something that's like, would be more definitive. So, correct. I mean, nausea and vomiting, the fact that she's having nausea and vomiting could be presumptive to pregnancy because most women do have nausea, vomiting in the first trimester.
So, for presumptive, this made it easier for me to understand.
Okay.
Presumptive is what the
We got a
woman
heartbeat.
experienced that makes her
She's
she's
pregnant.
pregnant. Probable is what an outside person can
Detect.
detect,
Mhm.
which is a probability that
Right.
she's pregnant. And then it's not until you actually have signs that are inexplicably you are pregnant.
Right.
Ultrasound,
Blood test.
fetal heart rate,
Right.
fetal movements, where there's no other possibility.
Right, because a fetal movement can also, you know, like definitively, you want to make sure that it is fetal and not something else. But correct. So your nausea, vomiting, breast changes. Okay, nausea, vomiting, breast changes. What's else is on the list for presumptive? Urinary frequency. Does she have that? Fatigue. Sometimes heartburn. Quickening. Right. See, I
What's
wanted you
that?
to say some of those other things that, again, quickening.
What is
which
that?
It's just it's not real fetal movement, but it's
The butterfly.
the butterflies. Okay? The butterflies type thing. Okay? Now, in order to get a positive, you must have something like heart rate. By ultrasound or by Doppler. Okay, fetal heart rate. Those things that it can't be anything else. It can't be anything else. So again, you might be tested on something from the list and have to decide if it's a presumptive, positive, or a probable sign of pregnancy. Okay? Yeah, right? Can you, what's that?
So what is probable?
Your probable is, just like he said, it's those things that are going to show signs, outward signs. such as abdominal, you know, when she starts showing. What else is on the list?
It's the Goodall sign, which is softening of the cervical tip. The Chadwick sign is the violet and bluishing of the color of the vaginal mucosa and cervix. The Heger sign, which is the softening and flexibility of the lower uterus.
Okay, so when the doctor does an exam, those are things, or the provider does an exam, those are things that he's going to, or she's going to see in the patient, okay? So there's a change in the mucosa of the vaginal canal, the cervix softens, and the other one is part of the uterus will soften in the exam, okay? Very good. So, can you disclose her results to her mom?
With her permission.
With her permission, but without her permission, no. You cannot, because her pregnancy belongs to her
Reproductive rights are outside of the parental.
or outside of parental consent, no matter what. I was shocked, guys, that like kids aren't considered adults till 21 in Mississippi. Wow, that was new information to me. Because apparently Mississippi's the only one. So, no, I think that she says there were 2 states, so. Her mother's told that you must do an exam on her daughter and asked her to sit in the waiting room so that you can do the exam in private. And her mother reluctantly agrees, but wants to know why she cannot stay. How do you respond? Again, go back to what I said. We can do it in a way that it's not threatening to mom, you know. Like, I just think it'd be more comfortable because the type of exam that we have to do, that if you step out, it might be easier for her, you know.
It's already embarrassing to
It's
a
always,
15-year-old.
yeah, absolutely. And then to have your mom sitting there, you know. So, and we want to make sure that we do it appropriately so that it doesn't cause more friction between mom and daughter. Can you imagine? Would you want to go home? Probably not. So you listen for fetal heart tones, which are 140 in her lower mid abdomen by Doppler. What is a Doppler?
Like a little that listens to the heart rate.
Which is an ultrasound. It uses ultrasound waves to pick up fetal heart tones. So fetal heart tones in fluid will give off waves in the fluid that can then be picked up by ultrasound. Okay? So, what type of indicator is this? A positive indicator for pregnancy, right? Because we have fetal heart tones. After explaining to the patient what the findings are, she begins to cry and say, I just do not know what I want, that I want this pregnancy and want to know my options. Okay? So how do you respond?
Give her her options.
Give her her options. Okay? Again, you're never going to be tested on state law. So you don't have to know what Mississippi law is necessarily until you start practicing in labor and delivery. Okay? But you do want to know if you ever get into labor and delivery, you want to know what the law is. I'm not familiar with it. I haven't been here that long to know. But again, standard is 20 weeks is viable. Anything before 20 weeks is considered non-viable, which means that it can be terminated. Okay? Anything before 20 weeks can be terminated. In Louisiana, because you know it's really more of a Catholic state, in order to terminate in a hospital past 20 weeks, there has to be documentation of risk to the mother or lack of viability to the baby or risk to the baby. So there's a lot of standards. They do still have abortion clinics, however. But again, in the hospital, you cannot terminate past 20 weeks in Louisiana. So again, you can have your own personal feelings about it. but we cannot let those feelings overlap, okay? And we want to give her options. So if she's less than 20 weeks, then her option, she still has an option to terminate her pregnancy. After explaining to the patient what the findings are, the patient begins to cry and say, I just do not know that I want to be pregnant. Wants to know her options, which we talked about. Is her response to finding out about her pregnancy appropriate?
Yes.
Is that a normal response?
Especially for a 15-year-old.
Absolutely, because even for someone who wants to be pregnant, we go through stages of finding out. And usually the first stage of finding out is like, oh my God, my life is going to change forever. And so even to someone who really wanted to be pregnant, they're still going to go through that stage of, what did I get myself into? So her response is very appropriate, even if you take out the whole scenario about her age. You with me? So, and we just need to be sympathetic and a good listener and not judgmental at all. So today is July 17th. Her last menstrual period is March 7th. Based on her last menstrual period, what is her due date and how many weeks is she today and what trimester is she? Okay, so Nagel's rule. Who knows Nagel's rule?
Add 7 and count them.
That's how we can. Okay, so you subtract 3 months from the first day of the last menstrual period. Subtract 3 months. So March, go back
February,
to January.
December.
Add 7 days. So it's January 17th.
March minus 3 months is December.
Yeah, December.
Okay, so
90
December,
days.
sorry, thank you. December, January, February, March, thank you, I'm counting on y'all here. So December 17th of this year, okay, you don't add a year
Okay.
in that case, because it's the same year. You with me? Okay, so take your birthday. What's your birthday? Now, do the opposite. So take your birthday, subtract 7 days, and add 3 months. That's when you were conceived. Okay?
Wait.
Y'all all wanted to know that, right?
So,
Y'all
March.
all wanted to know what was being celebrated.
All right, subtract 7, then add 3 months.
Right. So, again, that's a great point, so we're going to talk about this. Nagel's rule is based on the fact that every woman ovulates every 28 days. Do we? No. We know every woman does not ovulate every 28 days. Some women actually ovulate on orgasm. Whew, wouldn't want to be her.
All right.
Somebody else.
Scare my heart.
Some women actually ovulate twice a month. Okay? So, again, this is the best we can do when it comes for Nagel's rule. That's why we do an ultrasound at about 16 to 20 weeks. Because it's before genetics kicks in. Because after that, genetics kind of kicks in, so your size is more based on your genetics. It's before that kicks in, and it gives us a more, a better date to how old you are, how old the baby is in utero, by measuring the long bones of the leg. So we do that. That is the reason we do that ultrasound, amongst other things, to pick up other possible deformities that can be picked up in ultrasound. But that's kind of important. So what if those dates are different? Then which one do you go by? The ultrasound. Okay, so if they differ, then we're much more likely to go by the ultrasound date than by mom's last menstrual period. Okay? So, and again, because we're all different, lots of things can change that when it comes to the due date, but the best we can do is Nagel's rule until we have confirmative in an ultrasound, so that's what we go by. You will be tested on it.
So we should
On
track.
Nagel's rule?
Two questions, I just
We should
did.
track 3 months and
How
7
you like
days
that?
from last period.
Okay,
Wait.
you will be tested on it because it's that important.
So the name's wrong.
Nagel's rule.
You subtract, or you add 7 days.
You subtract 3 months, add 7 days, and again, most of the time it's the following year,
Yeah.
except in the case that it's the first 3 months of
From
the
last
year.
period. Okay.
Okay.
What was the thing that you said, with the conception date? Do we have to know how, the conception date or whatever? You said something
I
about.
think that is that.
Is it
It's
same
Nagel's
thing?
rule.
Okay, I thought if you
That's-
said something like
right.
add 3 months.
No, I was to do it for you,
Oh, okay.
to find out when you were conceived.
Oh, okay.
So you can take Nagel's rule and turn it around
Oh, okay. I see what you're saying.
and figure out, when you were conceived.
September,
Okay,
November.
now,
I was confused.
what blood do you anticipate that we're going to draw now for pre-labor blood work? What blood work needs to be drawn when somebody gets pregnant? Does anybody know? Okay, so that's a great thing. Only if you're worried about the pregnancy will you find out the HCG levels, okay? Because in those first, I want to say it goes to 12 to 14 weeks, the HCG level actually rises and then it comes down. So if you're afraid that someone is losing the pregnancy, okay, you can draw the HCG levels to find out if it's a viable pregnancy. Okay, if the levels are where they should be at the point that she is, then it's usually a viable pregnancy and she's not terminating. But again, we're going to draw HCG levels if we're concerned that she might be terminating. And okay, so a CBC. Why is a CBC or a hemoglobin hematocrit? Because that's the important part of the CBC that we care about her, right? So why do we care about that?
She's anemic.
Anemic. So, this is the thing, is that in pregnancy, what happens is as the pregnancy progresses, the fluid plasma volume increases. Are you with me? So when the fluid volume increases, what happens to your H&H?
The drop.
It drops. Does that mean she's anemic?
Yep.
Not really if she started out okay. So we call that pseudo-anemia in pregnancy because she's really not anemic. But you may see a drop, but we need to know now because if she's low now, can you imagine what's going to happen when that plasma volume goes up? And what is our H&H, what is our red blood cells good for? What do we need them for? Transport oxygen and nutrients. Now it's not just her that we're transporting to, right?
Right.
We're also transporting to who?
The
baby.
Baby. So we have to make sure that she's not only oxygenated well, but also that the baby's oxygenated well. So an H&H is very, very important. So what other blood work might we draw on this patient who's in her prenatal visit? Okay,
Blood type.
so we're going to go, let's start with the STDs. So that's great. So why do we need to know if she's got STDs?
See if the baby can get it.
Okay, so that we can treat her now while she's pregnant, because very often we can keep it from crossing over to the baby, which in turn could cause some abnormalities to the baby. So we're going to do STD testing. What test? HIV, syphilis,
Gonorrhea.
Chlamydia.
not necessarily herpes unless we see lesions or she has a history. Okay.
Gonorrhea.
But with a history or lesions, we definitely want to make sure if she has herpes. Some chlamydia, gonorrhea,
HBsAg.
very good. And so
Hepatitis B, surface antigen.
but that's That is something we're gonna draw on, not necessarily in the STD, but you can get it from STDs. So yes, the hepatitis B, it is in that classification. However, even, you can get it in other ways, is my point. So, Emily? What's that?
The RH factor.
Okay. Now, this is not, but yes, we are going to draw her blood type and RH. Okay, so we covered all the STDs. Y'all got all that? I just want to make sure. So, hepatitis B, syphilis, gonorrhea, HIV, chlamydia, AIDS, HIV. Okay, so we're going to draw all that to make sure, and then we're going to do, and so we'll get back to that. Right. So, because that isn't under the infectious disease, which again is really where the hepatitis B also goes. And so, so now we're going to talk about RH factor, the mom's blood type and RH factor. Okay. So, why do we need to know mom's blood type and RH?
Because it might not be compatible.
Okay. Because she may not be compatible with the baby. Okay? So, remember, we're going to go back just a tiny bit to anatomy, because I know it's been a while probably. And so remember, our blood types are A, B, and O, and AB, both. So remember, you either have it or you don't. If you have it, then it's no big deal to get it. If you don't, then you don't want to see it because you're going to react to it. So you either have A, you have B, you have both, or you have nothing. Same thing for RH. You either have it or you don't. If you have it, no big deal if you see it. But if you don't ever want to see it because your blood's going to react to it. Okay? So it's the same thing in utero, having to do with the baby. So if mom does not have RH, and the baby does have RH, first of all, we never really mix blood in utero because at the placenta, it really doesn't cross over unless it does. Okay, so if there's a tear or any bleeding in utero, then it might cross over and mom might see baby's blood, but normally it doesn't. Okay, so if there is, that's when mom will react to the RH in the baby's blood and build up antibodies against it. Okay? Now, most often those antibodies won't affect that pregnancy, but future pregnancy, she's got the antibodies, so if she ever has another pregnancy that is an RH positive, then she's going to react to it and try to destroy it. Okay? So what do? We need to know that so that we need to keep her from building up antibodies. Okay? We don't know what the baby is in utero unless what? There is one case, one scenario that mom who's RH negative will never have to get Ropium. Does anybody know? What?
If the dad's the same thing?
Very good. 2 negatives can't make a positive. Right? Go back to your anatomy. 2 negatives can't make a positive. So if you know that dad is negative, and this is an educated mom who's negative and she really doesn't want Rogam, she can refuse because she knows her baby's not going to be positive. Okay?
So you can check
We
with
have
the
to know
dad.
baby daddy.
Yeah.
What's your blood
Okay,
type?
so it has to be someone who is educated enough to know that. Because does anybody know what Robium is? What is it?
Is it made for monkeys?
No, but it's made from blood.
Isn't that medicine that protects the baby?
It's a blood product. Did you know that? No. So men actually go who are Rh negative and get injected with Rh positive blood to build up antibodies and then donate their plasma to make Rogam for women. Go thank a man. Why don't women do that? Because they could be pregnant one day. You don't want them to have antibodies, right? So men have to donate, have to do this, go through this process to make Rogam. So when a woman needs Rogam, again, she's going to go and be type A crossed to make sure she's compatible to the blood product she's going to get this Rogam. Okay? So can you imagine? You're not gonna get that at this level, right? Because we don't do blood products. So if you're asked to give Rogam, no. The answer is no. You cannot give Rogam because it's a blood product. Can you imagine some cultural issues? Yeah. Because again, it's a blood product, and we know there are certain cultures who are religious sects who cannot have blood products. So remember that. So, why do we give it? When do we give it? When do we give Rogam? Does anybody know? After they deliver, because again, that's the greatest time of blood seeing blood. You can see why, right? So, after delivery, and when else?
Before the next pregnancy?
No, because if you, okay, so keep in mind, what we're doing is we're faking the body out. So we're giving them someone else's antibodies, so they think they have antibodies, so that they don't build up their own. So we're really faking them out. So we're giving it to them at the time that they might be susceptible to building up their own antibodies, which is at delivery, as well as another time in pregnancy when the baby starts getting bigger, okay? So right around 28 weeks, the baby's starting to grow. The placenta is attached. We start having the potential for possible blood leakage in the baby. So we know that if we give it at 28 weeks, those antibodies are going to cover her to delivery, or at least close enough to protect her along the way. Okay? So that's why we get a blood type in RH. And then, what was the other thing you said that we're going to draw on this?
In regards to that?
Rubella. The rubella level. Now, why do we do a rubella?
To see if you are immune to it?
To see if you're immune to it. Because we know we don't want mom to get rubella during her pregnancy because it can have a tetragenic effect on the baby. Okay? So we want to be aware of it. Now, are we going to inoculate her during pregnancy? No. But when are you going to want to know her rubella status, especially after she delivers on postpartum, because she's going to get a inoculation before she goes home. Because guess what? Even though we tell them don't have sex for 6 weeks,
They sometimes do.
right? She could be pregnant by the time we see her again. So we're going to give her that rubella shot before she goes home. Okay?
I just wanted to clarify something. On the Rogam, we're going to give it to after delivery and at delivery and at 28 weeks?
No, 28 weeks, and then after delivery, it's within 24 hours of delivery. Okay? Because again, that's when her body might be building up antibodies. Now at this point, however, we are going to find out what the baby is, because if the baby's Rh negative, does she need it? No, she never did. Okay? And there's a 50-50 chance if dad's positive, she's negative, that the baby might be negative. we have to give during pregnancy because we don't know. But at delivery, we're gonna find out what the baby's blood type is and then decide if she gets Rogaine.
If there was concern, can't they do UES and, no,
For what? What are you saying?
for taking blood type off of umbilical cord?
Right, but that is very invasive, and again, you know, unless there was a contraindication, you wouldn't want to put the baby through that because it can, you know, that alone can terminate pregnancy. I mean, it's safe enough for if we have to do it, but we don't want to do it if we don't have to. And for something like RH negative, again, because there's a great chance that, you know, we're putting them through a lot for nothing. Because again, even if it doesn't hurt the baby, you know, by doing it, we can put something in there, like it can put them at risk for chorioamnionitis or, you know, infection in utero.
So, do they,
mhm.
I'm just a little confused. I just want to make sure I'm thinking
Yeah,
about it right.
please.
So if the way they test for the RH is they test the dad, like, 'cause I don't remember.
No.
Okay.
They test mom.
And if she's negative.
Her blood type and RH. If she's negative and we don't know dad,
Okay.
then you know
They still-
they have to give her Rogaine to protect just in case the baby is positive. So
Okay.
it's only a problem if mom's negative
Okay.
and baby's positive or unknown.
And
Okay.
they'll find that out as soon as she delivers.
Once she delivers, we're going to test the baby's blood to decide whether or not she needs Rogaine after delivery.
And if she's positive, we don't have to worry about it at all.
If the baby's positive,
If mom's
she was
positive.
right.
If mom's positive,
If
we don't have to
mom's
worry about it.
positive, we don't worry about Rogaine at all.
Okay.
RH positive moms never have to have Rogaine. Because remember, those are the antibodies that,
And if we
we don't want
do
her
know
to.
dad and mom are both negative, we don't have to worry about
Then
it.
the baby
right?
should be negative.
Then we know the baby can't be negative.
Okay.
Two negatives can't make a positive when it comes to the RH factor. You with me? Okay, so that's a lot of blood we're going to draw. Okay? But those are the things we need to know to give the patient the best care when she's pregnant. So what physical adaptations do you anticipate that you need to discuss about what to expect? So we know, we already kind of talked about the cardiovascular and the increase in plasma volume, okay? So what type of patient might that cause a problem with in pregnancy?
Renal patient,
A
cardiac patient.
cardiac patient, okay? Because again, even though women are usually young and healthy, okay, we also know that at this point in life and for the last probably 15 years, we've had women having babies who were born preterm. So there might be some cardiac issues, okay? So, or if she just has an anomaly already. But anyone who has a history of a cardiac problem, again, we want to watch for issues at this point once the volume goes up, because that just puts more pressure. What about our kidneys?
Big increase in size.
So they have to filter more.
Your GFR goes up.
Your GFR goes up. Very good. Somebody's been studying. Very good. So your GFR goes up. So it's a normal finding for a woman to have a higher GFR in pregnancy. Again, the more filtration, because she now has to filter for the baby too, right? Very good. What about musculoskeletal? Are there any changes having to do with musculoskeletal? So she's going to increase weight and volume, so she might have a few more aches and pains. What else?
Softening of the ligaments.
Softening of the ligaments. Good job. So as the pregnancy gets closer to term, her ligaments soften so that she can deliver. So women will often have a lot of hip pain, a lot of groin pain, just from that softening of the ligaments. As well as, keep in mind, round ligament pain. Very common for a woman to have round ligament pain during pregnancy. That's the ligament that holds the uterus in place, okay? And stretches to hold the pregnancy. And so very often it'll cause pain. What about GI? what GI changes might go on?
Constipation.
So she usually has vomiting through the first trimester. Okay? So for the first trimester, it's not uncommon for her to lose weight. Now again, we don't want her to lose more than 5% of her body weight, okay? And we may hospitalize her if she loses 10%, okay? And there is a diagnosis in pregnancy called hyperemesis, which is uncontrolled vomiting. That's a little different than just morning sickness, okay? So can you also see, now the motility slows down in pregnancy, especially the closer you get, because guess what happens to the intestines as the baby grows?
They're getting pushed everywhere.
There's no room. Okay, so those intestines are going to go up and out. So the motility is going to slow down, and it's going to put a lot of pressure on our diaphragm. Thus, heartburn and all those other things that go into it. Okay? So we want to keep that in mind and let her know. What about reproductive changes? What?
Your uterus is growing.
The uterus enlarges, okay? It is usually okay, as long as there's not complications, to continue reproductive, having intercourse. It's usually not a problem unless there's any signs or risk of losing the baby. Okay, so any bleeding, anything like that, we want to make sure that she knows to watch for those things. We don't want bleeding during pregnancy because that's not a good sign. That's usually a sign that something's wrong. We talked about respiratory, right? Because everything's getting pushed up. There's not much room for lung expansion. So again, and we need to make sure she's got good respiratory oxygen exchange, because if she's not getting enough oxygen, what's happening to the baby?
They're not getting enough.
They're not getting enough oxygen. Okay? What about skin changes? Well, we kind of talked about, or I don't know if we did, you'll get a dark line. Women will get a dark line down their abdomen. It's benign, no big deal, but it is a sign of pregnancy. What's that? Areolas get darker. Stretch marks begin. We want to encourage her, especially as a young mom, to maybe take care of some of those things ahead of time so that she doesn't end up with these long-term stretch marks. So we want to keep that in mind. Okay? So
You talk about the linea nigra.
the linea nigra, yeah. So normally rashes are not abnormal in pregnancy, but not normal. I mean, that would just go along with maybe some hormonal changes. A lot of women will end up with color changes on their face, what we call a pregnancy mask, increased acne. Some of those things will all happen. Neurologically, further in pregnancy, those hormones very often will give you that pregnancy brain. Okay, so you're just kind of a little more forgetful, can't always keep it together, especially further down in pregnancy. Okay? But otherwise, neurologically, they're intact, and guess what? It comes back after you deliver. Okay? No? Okay. Well, I don't know. I guess it depends. It depends on where you're at in life. Okay. So, what about endocrine? Not necessarily.
Your
But let's
hormones are all
talk
crazy.
about diabetes, okay? Let's talk about diabetes in pregnancy, okay? So, very often when someone has diabetes prior to pregnancy, whether it's controlled by medication or not, most medications, we don't want them to continue because there's no real studies with pregnancy. And guess what, guys? Really, there's no real control studies on any medication in pregnancy. None.
That's scary.
I know, but you go sign up during your pregnancy for them to study it? No, that's the problem, is that we don't have anybody who will volunteer during their pregnancy to try new med. And we don't want to. I mean, obviously, I'm playing around with that, but, you know, so, but we do what we can do with what we have, okay? And so we have to keep that in mind. So the thing is with diabetes in pregnancy, because of the extra demands of the pregnancy, first of all, in early pregnancy, what happens to someone who's a diabetic prior to? Well, they start throwing up and everything, so really it's easier to control their blood sugar, okay? Because of the changes in the hormonal changes, so very often their insulin demands are lower because they need less because of the throwing up. So, but as the pregnancy progresses, sometimes the demands go up. But what does happen is because of the fetus and the placenta, women in pregnancy often will become insulin resistant, okay? And so they'll get diabetes of pregnancy or gestational diabetes. It goes away once they deliver. However, statistically we know that they're much more prone to having diabetes later in life if they had diabetes during pregnancy, okay? We know that, because it's that insulin resistance. So you'll see a lot of pregnant women on insulin. We give them insulin. Number one, because we have to control it. So usually around 32 weeks of pregnancy, we test every pregnant woman for diabetes because it's that high of a risk. So we do a glucose tolerance test. Nasty.
Around
Thought it was after I had kids.
Mine
So I
tastes
didn't
like a
have to go
watered
through
down
it. Because again, medicine changes, guys. They didn't test me for diabetes, you know. So, but again, because of the high risk for it, we test every pregnant woman. If she fails the glucose tolerance test, then we try to control it with diet. And if we can't control it with diet, then we do insulin. Okay, so again, it goes the same route of let's control it with diet, and if we can't control it with diet.
I have a question.
Mm-hmm.
I'm sorry, somebody else said your name first.
Oh, that's okay, you can go ahead.
My cousin has diabetes. I'm not really sure, but she's had it all of her life. Well, she had her first child and it was fine, but she got pregnant. She lost the baby at 22 weeks, and then got pregnant again and lost the baby again at the same time. And they told her that she probably won't be able to carry anymore.
Right. And it goes back to the demands of the circulatory system and the inability to control the sugar.
Yeah.
And so remember, sugar in the blood is like having glass inside your blood. Think about it that way. The sugar in the blood is like having glass, and it's destroying all the tissues and causing plaque buildup from the damage. Okay, so the more times and the more uncontrolled somebody is, the greater chance of losing. And obviously, most babies who are born to diabetic moms are what?
Diabetic.
Big. More sugar to feed
Big
them.
old
More
babies.
sugar to grow. But does that make them healthier?
No.
No.
A lot of
It
times
doesn't
they're
make
sick,
them
huh?
healthier. Very often it makes them sicker, okay, because they are so large.
What's
So-
the chances
I
of the
think-
baby being a diabetic if the mother is a diabetic?
So, by genetics, maybe, depending, but remember, guys, and this is, and I just want to throw it out here, food for thought, having to do with diabetes. We're discovering that, yes, there's a genetic tendency to it, but do you know that most diabetes start as a viral infection that attacks the pancreas? I know. And this is like on the cusp of, okay? And truly, so real quick, I'm going to tell you a story. I love stories. So I had a patient I had in my clinic who was probably about 13. She was a diabetic. She had been diagnosed for about 2 years. Her mom got diabetes about the same time she did. Insulin, type 1 diabetes. Like, you gotta look at the connection, you know? So did they both get this virus at the same time? So I don't want you to go around worrying about viruses, you know, necessarily, but truly, I've heard this too many times to ignore. And I'm not an expert on diabetes, but you can't ignore it. You can't. And so very often, I think there's more of a connection than we think. And it just happens to be that it attacks that system. I don't know. I know y'all gonna go look that up. Look up that research and come back and let's talk about it. We're gonna take 5 minutes. Go to the bathroom and come back. There's a lot to talk about.